Okay, that is Cone syndrome. I don't know if we should go for a break, but if you can just indulge me with a little more time, let me just teach hyperparathyroidism, I beg, then we'll go for a break. It's not too much, it's not a very big topic. It comes out in the exam. Things that can confuse you is Paget's disease. It's got a biochemical picture that you need to know. I will send that table to you guys. Everybody has to have that table in their brain, not just at their fingertips, in their brain. You must be able to wake up and picture that table. You must see an AKT question, you picture that table. That table has about 10 conditions. One of them is Paget's disease. One of them is primary hyperparathyroidism. One of them is secondary hyperparathyroidism. One of them is tertiary hyperparathyroidism. One of them is vitamin D. How do you fail a question on vitamin D? When they've given you that is 30,000 international units, they say it's 50,000 international units, some candidates become confused. When is it above? When is above 25, what do I do? When is above 50, what do I do? Less than 50, what do I do? Less than 25, what do I do? These are things that we will touch. Don't fail them in the AKT, please. I beg of you. Well, our focus now is hyperparathyroidism. And today you will notice that I've not done too much, a little here, a little there. Although you know that that's my principle. You know that that's how to pass the AKT. I've not done it because we have too many. Endocrine has just too many things to cover. And so I've tried to be a good boy today. And what I'm doing is I'm trying to stay on the topic. Sometimes it pushes me away. It says, how would you talk about this thing and not talk about it here? Okay, so primary hyperparathyroidism, you see a question in the AKT, they are talking about groans, moans, and abdomen. See, how do you fail questions when they paint things very easily? A patient with renal stones, that's what we call abdominal colic. The patient is in pain, is moaning. So the patient has renal stones, and the patient is groaning or moaning. So groan stones, you're already thinking about this patient has hyperparathyroidism. It's a picture in the AKT. Look out for how they want to destabilize you in the AKT. It's just like that patient that has gone to Thailand and is having red eye, but he has been having pain on urinating. That is, don't fail questions in the AKT when they give you a clear picture of a triad. Is that patient that cannot pee, he cannot see, he cannot climb a tree? Okay, well, this is my focus, primary hyperparathyroidism. I just thought I will just make it simple. Please keep your life simple. Don't complicate it. I was looking at primary hyperparathyroidism months ago, and I saw a book with 3 pages, only primary hyperparathyroidism. Don't read that book. If you want to read that book, read it a day after your AKT. In fact, you can read it 1 hour after your AKT. But for your AKT, please keep things simple. Read only 3 lines. What are those 3 lines you need to read? Well, my friends, whenever it comes to primary hyperparathyroidism, you need to know the biochemical picture. I use CPP or CAPP, depending on whether you want to know all of them, as the way to go. Is that the C is the calcium, the P is the phosphate, and the P is the parathyroid hormone. That is the first easiest way to clinch a question on hyperparathyroidism. Know whether calcium is high or low, know whether phosphate is high or low, know whether parathyroid hormone, which we call parathormone, is high or low. But in the AKT, primary hyperparathyroidism, first of all, let's talk about the parathyroid gland. There are 4 glands. In the AKT, in the human body, there are 4 glands. And those glands, they produce parathyroid hormone. Let me just give a brief basics. Let me not call it pathophysiology. 4 glands producing parathyroid hormone. And these glands will usually respond to low calcium. So anytime calcium is low, what do these glands do? I'll tell you, they start to produce parathyroid hormone. And anytime parathyroid hormone is going up, calcium level goes up. That's how they help calcium. And if you don't know, calcium is high yield, not only in your exam, not only in your life as a GP, but it's high yield to your body. Low calcium, you will start to have a lot of problems. Low calcium, some patients have landed in hospital because of low calcium. They will be confused. Hypocalcemia is a cause of drowsiness. They will be extremely sleepy. That 76-year-old lady who is very drowsy, who is lethargic, and who has suddenly become confused, please check her calcium level. It is hypocalcemia. Please go and know the normal calcium level if you don't know. Some people will think it's 2.2. Go and know it. Well, my friends, if you don't know the normal vitamin D level, you need to know it. So whenever we're talking about parathyroid hormones and we're talking about thyroid gland, you need to know normal calcium. You need to know corrected calcium. You need to know normal parathyroid hormone. You need to know normal levels. You need to know normal everything, normal phosphorus. You need to know normal alkaline phosphatase. Don't fail these things. Well, I'm not going to do that because time is gone and I've just begged you for some time. So let me just focus on this. So I just wanted to paint a picture that anytime calcium level is low, parathyroid hormone steps in, vitamin D steps in. These are the brothers. They come and say, calcium, what's happening to you? You are falling down. They raise it up. One raises it up from the left, one raises it up from the right. How do you feel things that have been painted to you? Anytime you see low calcium, you will see low vitamin D. What does parathyroid hormone do? It starts to raise them up. If vitamin D is not low, parathyroid hormone has sprung into action. Then what happens is that vitamin D raises it up from one side, parathyroid hormone raises calcium up from the other side. They basically sustain calcium. How does parathyroid hormone, how will it do this? Well, I'll tell you in 3 ways it can do it. It can raise blood calcium level by increasing the absorption of calcium from the intestine. That is a question you can see in your AKT. Again, it can cause what we call reabsorption from the kidneys. So remember that calcium can be produced in the kidneys via parathyroid hormone, making sure that it reabsorbs the calcium that is being lost from, not produced now, but the one that is being lost in urine. It sweeps it back to the body. It says, don't go. It pulls the hand. It says, calcium, give me your hand. It pulls it back into the body. It says, don't go anywhere. That's what parathyroid hormone does. So let me paint that picture again. Parathyroid hormone will go to calcium. You see that calcium is very low in the main area, which is the blood. So it goes to the intestine and say, calcium, what are you doing there? Calcium say, I'm lost. Calcium say, I'm drowsy. Calcium say, I don't know what I'm doing in the intestine. It goes into the intestine. It pulls calcium. It says, come back into the blood. Well, some of it wants to escape in urine. Calcium quickly cites it. Parathyroid hormone quickly cites calcium. That calcium is about going out of the door. It pulls his hand. It says, calcium, don't go out of the door. It pulls it back. It says, come back into the blood. This is how parathyroid hormone works. So the third one is by decreasing urine calcium. So it decreases the amount that is absorbed in the kidney, and the one that is already in urine, it decreases the amount that goes out of the urine. It does all this and even much more. But let me not focus too much on the pathophysiology because there are areas where they like to ask questions. What are the areas? Well, parathyroid hormone, when you see a patient that is presenting with a tumor, then you can start to think, is this primary? Is likely to be primary. Primary hyperparathyroidism is a parathyroid gland tumor that is producing excess PTH. The treatment is this patient needs surgery. So that's the primary now. So before, what I was doing is I was giving you what we call a preamble. What I was doing is a basics. I've come to primary now. Don't fail the question. It's usually a tumor in the parathyroid gland that is producing excess PTH. How many times have you seen tumors today? Let me remind you. Cushing's, brain wahala, Cushing's, kidney wahala, they are producing too much cortisol. Again, we went to Crohn's. We saw that the adrenal gland can produce too much aldosterone. Adenoma can produce too much aldosterone. That is Crohn's. Now you are seeing another tumor. The tumor is in hyperparathyroidism, and this tumor is producing too much parathormone, what we call parathyroid hormone. How do you feel these things? Well, my friend, if you do not know, endocrine is a topic or subspecialty of tumors, now you know. The first 3 topics I'm teaching, everything is about tumors. There's tumors everywhere. You need to know tumors. Well, that's not our focus for today. So the treatment for this tumor basically is to do surgery. But how does it come? If you've read the question, you cannot identify the question using groans and moans and abdominal pains, that's abdominal moans. So the patient is groaning in pain because they have bone pain. The patient is got stones because it causes kidney stones. The patient is having abdominal moans because they're having abdominal pain. They are feeling unwell. If you have missed that clincher out, how else can you redeem yourself? It's in the biochemical picture. So picture CPP. If you are writing and you write CPP on a paper, what you can do is C, if you put an arrow beside it or under it, an up arrow to show that calcium goes up, you are doing well. P is going to be the next, phosphorus. If you put a down arrow beside it or down arrow under it to show that phosphorus is going down, you are doing well. And the last P is parathormone. Parathormone is usually always normal or high. So for it to be, let me repeat that. For it to be hyperparathyroidism, your last P is always normal or high. I'll tell you that it's usually high. Normal is just in a few cases. So you will usually see it as high. So what we are concerned about is the C and P, calcium and phosphorus. By the time we start to talk about things like Paget's disease, when we start to talk about osteoclast, osteoblast, when we start to talk about other bone conditions, you will find out that the acronym, rather than being CPP, will be CAPP, because we need to talk about alkaline phosphatase, what we call CAP. So the acronym is CAPP CAP. If you want to write CAP now, that's fine. But for this hyperparathyroidism, I have no much use for the A. My use is for the C, which is calcium. My use is for the P, which is phosphate. My use is for the last P, which is stagnant, actually. It's always high. Is the parathyroid hormone. So what happens in primary is that the C goes up, the P comes down. They are never friends. Someone has just quoted what I've just said now. I've told you that the friends of calcium are parathyroid hormone and vitamin D. Little wonder, anytime you see calcium going up, you see that the parathyroid hormone is going up and vitamin D is going up. But what is its enemy is phosphorus. Anytime calcium is going up, phosphorus will go down. That means in a question, if you are picking, they say that the patient's calcium is about 4 point something, is very high, and you go and pick the answer as a high level phosphorus, you fail the question. They are opposites. Calcium goes up, phosphorus comes down. So in primary hyperparathyroidism, in fact, in the whole of the hyperparathyroidism, all you need to know is what is happening to calcium. If you know what is happening to calcium, you are good to go. So what is happening to calcium in primary is that calcium is going up. Why? There's a tumor that is producing too much parathyroid hormone, and you know that anytime parathyroid, it will increase calcium by reabsorption and all the mechanism we talked about. So it automatically tells you that phosphorus will come down, and of course, you know what will happen to your parathyroid hormone. It will stay up. How do you feel it? With this picture, if you've missed out the diagnosis, with this picture, you can't miss it out. It is primary hyperparathyroidism. Well, these are questions that the RCGPC candidates are failing. So what I've done is I've made this very simple. This is simpler than licking ice cream. It's simpler than eating red velvet cake. This is enjoying a nice meal, my friends. So please don't fail it, I beg you. Well, secondary hyperparathyroidism is the next one I'll go into, my friends. If you see secondary hyperparathyroidism in your exam, it's usually not a problem with the brain tumor, it's a problem with vitamin D or the kidneys. Two things that cause it. The commonest one, in fact, another name people call secondary hyperparathyroidism is CKD, my friends. Well, the other thing that can cause it is vitamin D very low. So CKD on its own can even cause reduced vitamin D. So that's why most people just say CKD is is the second name for secondary hyperparathyroidism. So when you see secondary hyperparathyroidism, you may see aka CKD, you know we're dealing with chronic kidney disease in secondary hyperparathyroidism. So it's not a tumor. Primary is a tumor in the main gland. And I told you, for it to be primary, it means the tumor is in the local gland. So where is that tumor? Is in the parathyroid gland. But in secondary, it's not a tumor at all. It's usually, once you hear secondary, it is far away. It's a secondary cause because it's a small central cause. The kidney is the problem here. It's secondary because it's from somewhere else. The kidney is the issue here. So the cause will be vitamin D deficiency, and I've begged you to know when a patient is vitamin D deficient. And the second one is CKD. What's the treatment? Give the patient vitamin D. Simple. If CKD is the problem, do renal transplant. By the way, please know the two classifications of CKD in your exam. Based on EGFR, and you need to know which one is less than 15. That is end stage. Don't fail it. Some people don't know that 15 to 29 is stage 4. They keep saying it's 15 to 30. Please, 30 is not part of stage 4. Well, stage 3 is divided into 3A and 3B. How do you fail this thing? If you see 30 to 45, you know it's B. And if you see 45 to 59, you know it's A. Don't fail it in the exam. And as well, 60 and above, 60 to 90, you know what it is. Greater than 90, you know what it is. Please look out for end organ damage. But I know all of you know that one, and I'm not going to disturb myself with that one. The one candidate forget is the one that has the A's, the A3, the A classification. A1, A2, A3. Don't fail it in the exam. Less than 3, 3 to 70, greater than 70. Please, it's not 3 to 30. Less than 3, 3 to 70, greater than 70. My friends, that's not what I'm talking about today. When we go to nephrology, we'll look at that. We'll look at it properly. What we want to do today is talk about secondary hyperparathyroidism. And I've diverted there because you need to know everything about the kidneys. 125 hydroxycholecalciferol, liver. What is the equivalent of it in the kidney? You need to know. Causes of anemia. CKD is a cause of anemia. How does it cause anemia? The 5 mechanisms how CKD can cause anemia. You need to know. Again, those are not endocrine problems. They are nephrology problems. So I'll leave that for nephrology. But I'm just trying to challenge you, my friend. Know these things. They are not too difficult. Okay, so what's the biochemical picture now that you know how it will present and you know the treatment? Now you write your CPP, you know that calcium will be low here because the kidney is one of the producers of calcium. Now that the kidney is having problem, it cannot produce calcium. So what do? If the arrow of C is pointing down, you automatically know that the arrow of P in the middle, which is phosphorus, will be pointing up. How do you see that they say phosphorus in the exam is increased and calcium is reduced, and you do not know it's secondary, you pick primary? But why will you fail questions deliberately? It's not fair to yourself. Of course, I've told you that the parathyroid hormone will be high. It will be always high. So you don't fail that questions in the AKT, I beg you. Well, what is tertiary? Tertiary is usually as a result of untreated prolonged secondary hyperparathyroidism. So this patient has got secondary hyperparathyroidism and is not treated. What happens? It becomes secondary. So in the AKT, if you see secondary hyperparathyroidism lasting months, years, and suddenly there is a picture is different from secondary. So it's the patient has secondary, but the picture they give you is the picture of primary. Let me repeat that. Someone is getting confused. If you see the picture of primary in a patient that they say has secondary, how do you know? What do I mean? Someone is thinking now that the right patient had secondary hyperparathyroidism. No, they won't write it. They will say the patient had CKD. Sometimes the AKT will make it a bit difficult for you. They will put a picture of a use and is, and they'll put the one So how do you diagnose CKD? At least you need to have your results 3 months apart, 12 weeks. Don't fail these questions in the AKT. So they put the picture of your use and ease 12 weeks ago, and they put it now, and then you see that there's something wrong with this kidney. Okay, I think this patient has CKD. That's how they'll put it. Or they'll write that the patient has chronic kidney disease, past medical history. But you are about secondary hyperparathyroidism as your answer. But all of a sudden, rather than see your CPP as low, high, high, what do I mean by low, high? Low calcium, high phosphorus, high phosphate. So rather than see low, high, high, you see high, low, high. You say, but this is the picture of primary hyperthyroidism, high, low, high. That is tertiary, my friends. I don't know how else to explain these things. That is tertiary. If you do not understand this thing, come and meet me, accost me in the drills. Say, Dr. Ola, you cannot move forward. I don't understand this thing. I thought this can be the easiest. Any candidate in the AKT can have it. But if you feel that that's not the easiest, that's why I'm here. I will make it in another way that will be easy for you to understand. So please come to the drill this afternoon when we are doing other things, because in the drill we are going to be talking about gynae. In the drill we will be talking about botulinum toxin. In the drill we'll be looking at cancers. In the drill we'll be looking at some admin questions. We are not going to be doing endocrine in the drills. So during the drill, just tell me that, oh, you asked a question, you explain something in the morning, I still don't understand. I will spend 20 minutes to re-explain to you until you understand. I will not go away. Please, we are
All I
committed.
want to
Yes,
all
please.
I want to get is the where you mention how to know if it's CKD, like the secondary picture. You see that they won't tell you directly. They won't. Of course, it's the kidney problem
Yes.
in secondary. They won't
Mhm.
go direct. So, like apart from the U and E's picture they can give, what other
Mhm.
things?
They
What
will
other
give the
ways can they
symptoms
ask the
of
question?
CKD. What are the symptoms of CKD? Uremia. The patient will start to itch, my friend. How do you feel it in the AKT? If you see a patient having uremic encephalopathy, think CKD. It could be. My friends, reduced urine output in the exam is not only AKI. Worsening CKD, you could see that picture. My friends, if you are not seeing deranged use and ease, you are seeing a patient with anemia and you have looked at the use and ease is deranged, what are you waiting for? It's CKD. Erythropoietin needs to be given to that patient. My friend, what you are asking me, the question you're asking me is to treat CKD as a topic. I am happy to see. If you stop me on the street, you say, Dr. Ola, treat CKD, I will take 25 minutes and touch CKD. I will finish our time on CKD. But we've got nephrology to talk about CKD. So we will do CKD in nephrology. Think anemia of chronic disease. If they start to ask you, the following patient has this, they write a lengthy question, 2 paragraphs, you'll be thinking that they're asking you about anemia and CKD. The question is, what type of anemia is this patient likely to have? That's anemia of chronic disease. That's CKD, my friends. Please, that candidate that asked me that question, you just want to push me into teaching CKD today. That is not my focus. CKD is nice. Anytime I see CKD, it's like I'm taking spaghetti and chicken. It is sweet. You need to sit down and dissect CKD. You need to sit down and enjoy CKD. Well, we're going to do it in nephrology. So that candidate, don't rush too much. You'll be able to identify CKD like the back of your palm. You'll be able to identify CKD from the first sentence in the AKT question. You'll be able to identify CKD by looking at only the answer. You will be that good. So let's leave that for now, but it's just knowing that the signs and symptoms, how CKD will come out in the exam. That's what you are asking. It can come out as anemia. It can come out as uremia. It can come out as biochemical information in your exam. It can come out as bone problem, my friend. CKD causes osteoporosis, calcium. So if you start to see a patient, the patient has got fracture, unexplained fracture, they've ruled out everything in the question, what are you waiting for? Pick CKD. That is the answer. That is what is causing his problem. Vitamin D is low. Well, if you start to see a patient having body pains in the AKT, with a picture of CKD biochemically, and you don't know that CKD will cause joint pains, muscle pains, things like what you see in whiplash injury. It will, my friend. It will cause tired all the time. So you can't afford. And what are the causes of CKD? You need to know them. What are the causes of AKI? You need to know them. Renal, pre-renal, post-renal. Where does acute tubular necrosis fall in? Where does renal artery stenosis fall in? Where does dehydration fall in? In the AKT, they will tell you the patient has been vomiting. How do you not know that they are talking about a pre-renal cause and not a renal cause? Renal cause is usually inside the kidneys, the tubules, the everything. Post-renal cause is outside. Before the problem comes, it will be dehydration. Not enough fluid is going to the kidneys. That is vomiting, my friends. That is excess sweating. A patient with certainly have AKI. I don't know if you know that. Hyperhidrosis can be very severe. It's a problem. A patient that has been vomiting for several hours now, please think AKI. If a patient has burns, what are you waiting for? It's a pre-renal cause of. So that my friend that asked me the question, you've just made me happy, you've made me excited. I don't want to be excited about nephrology. But my friends, this is how you have to be excited about these things. Whenever someone calls the topic AKI, just smile and take the person to town. You need to tell the person, I'm going to take you to town today, now that you've mentioned it. This is your approach to the AKT, my friends. Well, because I've begged you for time and you guys have graciously given me time, please let me move forward. So tertiary hyperparathyroidism, I hope all of you understand. For those who will still struggle, let me give you another clincher. They will give you a picture of a patient who is constipated in the exam. Constipation, think hyperparathyroidism. Why are they constipated? Calcium. Calcium causes constipation in the exam. I've told you, it's a 72-year-old lady who is drowsy, who has got constipation, who has got excessive thirst. She's always thirsty. She's having frequent urination. Frequent urination is not always diabetes mellitus in the exam. Think wide. Allow your brain to think. Don't cage your brain. It is diabetes insipidus in the exam. It is hyperparathyroidism in the exam. It is SIADH in the exam. Don't fail the questions, my friend. Don't allow your brain to have what we call lazy study syndrome. Don't allow your brain to be lazy. Exercise your brain. In fact, your brain when it's not doing anything. I mean, sometimes you should relax. Sometimes you should enjoy. But at least 1 hour a day, challenge your brain. Let it work for you. Okay, my friends, that is about tertiary hyperparathyroidism. It has the same picture as primary. The only difference is that it is a continuation of secondary. The only picture is that it is not caused due to a tumor like you will see in primary. The only thing is that you will see a few more tips that would show you that, well, this patient has what we call hyperplasia. So hyperplasia of the parathyroid gland can cause tertiary. And what you do is also surgery to remove the hyperplastic areas. Okay, so I just think that is a lot of information. I think we should just take a break now. I can give you up to 10 or 15 minutes break because what you are coming to do is more information. Please, thyroid disease, if any of you go to the AKT and fail a question on thyroid disease, I will be extremely sad. I'll be extremely sad because thyroid is easy. I'll be extremely sad because we are going to treat thyroid this morning. I'll be extremely sad because you see thyroid in your mocks. I'll be extremely sad because anytime we are doing endocrine, thyroid disease will be a bulk of the question, thyroid and diabetes. I'll be extremely sad because of many reasons. You will have low mood. You will have low mood because that question on thyroid disease that you failed may be the difference between passing and failing. The cutoff may be 71. You may have scored 70 and you just needed a thyroid disease question to pass. You will have low mood for weeks if you fail a question on thyroid disease, my friend. Don't do that, please. Pass all your questions on thyroid disease. That's why I say endocrine. You can easily get 9/10 in endocrine. You can see it now. You can see how easy the thing has become. It's like watching a film, my friends. Enjoy the movie. Okay, so let's go for a 10 to 15 minutes break. If you guys want longer, just put it in the chat box. We can do 20 minutes break. Please pardon that we've taken a lot of time. There is no time anymore. There is no time anymore. What I try to do when we take a lot of time in the morning, what I try to do is I shorten the drills so that you can rest and have time to do other things in your day. But please let us complete. We need to complete all teaching on or before October 1. Because from October 1, what we are just going to be doing is what we call high grade revision, what we call fingertips experience. We're not going to be doing topics again. We're just going to be playing with high points that come out in the AKT. Sometimes we'll do 50 points. Some days I'll be so excited, we'll do 120 points. On a very bad day, we'll do 150 points. Some days when the points are very super high, you will do 10 points. The people in the past plus are already seeing what I mean by point system. The other day, we're supposed to do 6 points. We went to 10. I was wanted to stop at 10. We went to 12. By the time I was asking them questions, they saw we have covered 15 major points. By this point, I mean, what are the causes of botulinum toxin? What are the indications for botulinum toxin? These are points because they come out in the AKT. So my friends, please, I want to beg you. I know that you guys have other things to do, and the AKT is just one of the things in your life. I recognize that. But the AKT is around the corner. I beg you, can you just give us extra time? Just a few extra time. So all the classes, any class that is overshooting the morning 3 hours, please just give, or 4 hours, give us some extra time. Let's just finish it. You can go back to the recording, because I know that after 4 hours, some people get tired. Go back to the recording. The part where you were tired, re-listen to it again. So let's take a break, my friends, and let's come back in 10-15 minutes time. Let's look at thyroid disease in whole. And if you've got any question, quickly, if you want to ask me one question before you go, or two, that's fine. Otherwise, if your question can wait for the drill, please ask during the drill. Is there any question? Okay. All right. Let's go for a short break and we'll be back.